So, welcome back. We first want to apologize for the technical difficulty. I know that several of our groups weren't really able to convene, and we're trying to get to the bottom of those technical difficulties. But we will hear from a few of the groups that were able to hold on to each other for long enough to have a conversation. And I'll start by giving the floor to Jim Allen, Dr. Jim Allen, who was working with researchers, who was talking with researchers.
Thank you, Lisa. And on behalf of everybody, I want to apologize to the research group who were just persevered. We were interrupted a couple times, so we weren't able to get together. And the conversation, because of time, just started to get going. But it was very impressive how quickly it went to a number of core issues. And I'll just summarize a couple of them. I thought one of the persons who spoke just really aptly summarized how this brought up and was situated at the intersection of research and culture. And this brought a number of important considerations that research has too often been ignoring regarding context. And one of those is a simple difference in suicide prevalence across communities. We saw information today, if you just limit this to the subgroup who receives IHS care, there's a tenfold difference across the sectors. And researchers have been ignoring the fact of this tremendous amount of diversity within the population. And the point was, we can't ignore that anymore. Another very important point that came up was just a moment of reflection that the talks today sort of kindled about how we go about developing our questions, our research questions. And often we're not taking into consideration this uniqueness. One person noted that assumptive worlds come out of our creation stories, and Westerners have those. Well, these communities do as well. So the challenge for research becomes asking these kinds of questions that are grounded in the community's perspective on suicide. And then finally, a non-Indigenous researcher from a different cultural group just offered some perspective of the relevance of this work and was heartened by its particular focus on spirituality and how relevant this is to other cultural groups within the United States, one of which she was a membership of, but how many parallels they were in terms of her own population group, her own cultural group struggle in the United States. So that's just a quick capsule summary. In just the brief time we had together, these points just exploded and they're very rich. I'll turn this over now to Justin for his section.
Thanks, Jim, and thank you, Lisa. Thank you to my group as well, the policy perspective group. A lot of resilience there with the technical hiccups, and appreciation. There was not a single complaint. There was just working through it and diving right back in, which was, I think, a testament to the importance of the topics and the desire of the members of the group to chew on these important topics. A couple of key observations. The first was almost everybody in the breakout commented on how impressed by and moved by the webinar sessions they were. And some of them knew some of the speakers, some of them didn't know, but everybody around the table was really, I think, gratified by the expertise and the approach that was taken to the content. We also hit on some momentum among the group to validate the shift away from a traditional biomedical model to the problem of suicide prevention to a psychosocial or community-based model. And there are different reasons for that direction, one of which is, well, the current situation, the current approach simply ain't working, or it ain't working well enough. That's pretty easy for everybody to agree on. This is a needle that, despite tremendous advances in neuroscience, has been moving in the wrong direction. And I say that as a psychiatrist and neurologist. So it's very, very important, I think, to hear that perspective, that this is a challenging problem, and thinking about it in traditional kind of Western medical ways hasn't gotten us to where we all want to be on this. And then a third observation was, I think, related to this point, which is some folks were validating, if not celebrating, a strengths-based approach to the content of the day so far. And at the same time, some of the researchers and policymakers in the room highlighted the challenge with that approach from the perspective of the evidence as published in traditional scientific literature contains evidence-based interventions in suicide prevention that are not focused on strengths. And when you're looking for published literature using strengths-based approaches, you really have a hard time finding much there. So how do we reconcile that? How do we get that published traditional Western scientific evidence out there so that we can use those kinds of strengths-based approaches? And in the meantime, what do we do when we're forced by one body or factor or force or another to really be quote unquote evidence-based? How do we balance that? So I'm not doing justice to, I think, where the conversation would have gone. And I think folks would be enthusiastic were they to receive an invitation to reconvene. Back to you, Lisa.
Yeah, I agree. Some of the themes that both you and Jim mentioned were coming out in our very short discussion. I wonder, Victoria, if something stands out that you want to amplify at this point.
Thanks, Lisa. We unfortunately didn't have time. We were just doing introductions and changing Zoom names, so we really didn't even get started. But I hope that there are other opportunities, as Justin mentioned, to convene this group, because I could see that there were, voices that wanted to be heard and conversations to be had. Thank you.
Yeah, and in my group, with the very small amount of time, the diversity and the depth of what we heard about as far as cultural traditions and strengths, and sort of even some of the challenges of trying to utilize some of the conceptions of things like generalizability and reproducibility, and some of the ways in which our earlier speakers talked about the limitations of positivistic or Western science can be a real hindrance to developing the kinds of evidence that typically is looked at within Western institutions. And one of the things that I'm curious about, if other people heard, was maybe a need to look at how we study or how we know what we know, and widening the scope to include more Indigenous ways of knowing. And I'm opening this up to the amazing planning committee members, if they have anything that they want to say about sort of scientific inquiry and what we heard this morning, what stood out to them, since the National Academies really is focused on research and practices for suicide prevention. And that's one tension that seemed very clear to me. Any committee members have thoughts that they want to share?
I would just say that it was a fabulous set of presentations, and I'm very much of the mindset that we need to have alternative ways of thinking both about evidence and about how we draw on or what we have to understand in order to move one successful intervention from one community to another. This is particularly true with Indigenous people because the religions, the language, the culture, even the place is so different in different conditions. Alaska versus Florida, or the West versus the East. But I think that the idea that it's hard for me because I started out as a clinician and really someone who was doing histories of people who'd done remarkable things, the civil rights movement or surviving cancer, and then came to do serious empirical trials of preventions for families. And it took me a long time to do that. It took me a long time to acquire those skills. So it's hard to say, it's hard to see how limited they are in contexts, for example, in which English is not the primary language, or in which people don't have access to schools and neighborhoods and healthcare systems. And almost all my work has been in non-traditional places, but I'm convinced that we need to reframe the way we think about the nature of evidence, and also what different kind of evidence, which is what do we need to know in order to be able to say that we could begin to take one program from one setting where it's been effective to another setting. What level of cultural brokers, what level of cultural knowledge, what level of resources in order to do that? Because I think that very often the attempt to take something from one setting to another is not well funded and not well studied.
Yeah. I'm wondering, and I want to invite other people to weigh in, but if indeed a lot of the teachings come from the land and a lot of the ceremonies and teachings that we heard about this morning are about the relationships, are those reproducible? And should we be thinking to ask different kinds of questions and taking the lead from Indigenous knowledge systems to get a better sense of what might be most important? And I want to sort of just invite folks who are on the call that maybe understand those knowledge systems better than I do, might want to take that one.
I'd just like to weigh in just a bit here. And I know there's a lot of folks who think there's such a thing as Native culture, and there isn't. There is not any such thing as Native cultures. There are thousands and thousands of very unique cultures. So it's going to take a lot of cultural humility and really sitting in the learner's chair and actually listening when people say this is what's healing for us. These are our healing ways. And Don said it so beautifully this morning. How do you study Sundance? How do you clinically study a healing ceremony, a powerful healing ceremony like Sundance? You do not. You do not study our healing ways. You might study the results, and I heard that as well. And that's fine. But I think the aspect and the idea of cultural humility, going into communities in a respectful, humble way and saying, please help us to understand. And then if everything isn't given, being okay with that. I got a chance. I was talking on in our private chat with the wonderful Dr. Khan John, because I know Sehotso Medical Center very well. I've done a lot of work with Sehotso and saw in action these wonderful traditional healers who are part of medicine, the medicine clinic at the hospital, in a place where people coming into the hospital are speaking in Diné. Now, if you don't understand it, that you're going to have to honor the traditional ways of the people in order to get the Western medicine to the people to heal them, it's not going to work. It's not going to work. So Sehoto Medical Center said, we're going to do this. We have a Hogan right there on the site of the hospital, and we have one in our outpatient clinic in about an hour away in Sanders. And they unite beautifully the traditional medicine, the medicine of the people, with Western medicine. And I saw it working in action, and I've seen it working over Turtle Island in many different places, how that medicine, the people's ways of healing, how the people conceptualize healing and wellness in the Anishinaabeg, in all over Turtle Island. Every way is unique, different, and beautiful. And it's about really listening when the people talk and they say, this is what healing and wellness looks like to us. And here's our ceremonies. Our ceremonies are ancient. They have not been peer reviewed. They're not written up in medical journals, nor should they be. This is sacred. This is sacred knowledge. This is knowledge that is evidence informed, evidence suggested. Will we ever get to the place in Indian country where our healing ways, how we heal, is evidence-based? Probably not. And I don't think it should be. And that's just an old woman's point of view. But I heard it over and over and over today. And I got validated. I got validated in everything that I'm doing all over Indian country. I heard it validated in different ways and in different words, and I'm grateful for that.
Thank you, Sade. So I'm wondering if I can steal from Dr. O'Keefe's go round and just invite folks that have been thinking about this, that have been working in this from many different perspectives, to just share a thought or an idea or a next step in sort of how, and this is sort of speaking to the national academies, this is speaking to policymakers and researchers and community workers and clinicians. What's sort of one takeaway from this? And I'll start with, I don't know, maybe Emily.
It's houses.
Houses, thank you.
On the street. So now everybody knows. Okay, thank you for that. And I keep coming back to this thought that goes a little bit deeper, and it's about who owns the knowledge. We keep coming and talking about evidence-based practice, and I think all of the panelists have really emphasized over and over again, these aren't cookie cutter interventions. These aren't things that we can do in one community and then modify it slightly and move it to another community. This is about traditional knowledge that exists in one place, and it's with that community. And there is knowledge there that belongs to that community that isn't necessarily meant to be shared. It isn't necessarily meant to be written down. It doesn't belong to anybody else. And that's really important to understand. And that's a major difference between indigenous ways and Western or European ways. In European ways, the knowledge is published, it's put in libraries, it's something that you can learn. Everything is accessible. And the more you learn, the better you are. But in indigenous ways, that's just, for many people, and I'm not going to generalize, but for a lot of different groups, that's just not the rule. There's knowledge that some people can have and knowledge that some people can't have. And we know that and we respect that. And so if that's the paradigm, you can't, there's just no way you can take an intervention from one place and decide, well, if I change the pictures on this intervention, we're going to use it in a whole other place and it's going to work, because it's just not. It's a whole different way of thinking, a whole different way of being. And we're so focused on evidence-based practices, and this has come up over and over again. And I want to challenge everyone to think, why are we focused on evidence-based practices? Some people might say, well, we want evidence-based practices because we want to make sure what we're doing is working. We don't want to waste something. But if you really think about it, it often comes down to money, right? How are we going to bill for these services? And why don't we just skip that step altogether? Because the communities know if they had the resources, they would be able to use them very well. Then they don't need to be filling out forms and documenting and publishing just to do what they would do normally.
Thank you. Dr. Teresa Brockie, would you like to go next?
Let's see. I'm just going to bring us back to those differences. But like we're at a place right now where we can say we're culturally different across the board, but we have a harder time thinking that suicide is not race-based. We still think that every youth is at high risk for suicide. And there are too many differences across communities that we can't continue to ignore those differences. Otherwise, it will be another 30 years before we're still having that same conversation. I'm going to be way more older, or I'm going to be dead, right? And we're still saying it's 30 years later and we have had no impact on the overall prevalence of youth suicide in Native communities. And so, and we've spent another, I don't know how many, $30 million, whatever it is we spend. We spend a lot of money on trying to address suicide. So ultimately, the system, the way that we think systematically, it doesn't work. And so I think that's a higher level issue. It's a policy level issue that needs to be addressed. We fund communities at the same level, whether their suicide prevalence or rates are out, are extremely high. And those that are extremely low or have no prevalence of suicide, we fund them at the same level. That's not the way that we work as Indigenous people. It's my responsibility culturally to care for those who have less than me, who don't have the same resources as I have. And so we've kind of lost that philosophy that grounds us in caring for those who are less fortunate. Instead, we flip that, right? We use those that are less fortunate to advocate for funding for our communities that do not have that high prevalence of suicide. And so until I think we change that way of thinking and go back to our own philosophies, we're going to still continue to have this problem, which that probably maybe has some culture in it or doesn't have culture in it. But that's kind of what I'm feeling after this morning. I think tribes are tired. Either, Alaska Native communities and tribes down here are tired of not having any change in the prevalence of suicide, and to see their own people suffering, that we really need to change the way that we do things. I'm done, Lisa.
Thank you. So I'm wondering if Dr. Michelle Kanjan wants to give us some reflections.
Hi, everyone. I'm here with Dolly. my little dolly won't leave my lap right now, but I don't know. I'm like, there's so much that needs to be done, but I think it's just the thoughts that come to mind right now are about deconstruction, like the need for unknowing and undoing. And just like Dr. Beardsley mentioned, like we have been trained in such a way that it creates these barriers for us to move forward as researchers, as healthcare providers, and even as tribal leaders. Sometimes we think the systems that are built and in place and the processes are ways that we need to just keep doing things, right? And we really need to change and make room. I'll give one example. One of the reasons that I cited for holding off on publishing some of my research is that the sacredness of the work, because I'm looking at outcomes of ceremony. And so there's the protection piece there, but there's also that misalignment with the whole process and the research process itself. I just become so conflicted. So, and then I get a lot of, I guess we'll call it constructive criticism from my peers and colleagues as researchers. Michelle, why didn't you draw blood before the ceremony? We need those other biomarkers. And I said, well, we chose a non-invasive approach to collect saliva instead, because it's against ceremonial protocol to draw blood. The body is so sacred during the time of ceremony so it's like I'm constantly having to explain, but yet the work is cited as flawed because I didn't follow protocol. So we constantly come up against these barriers. So people need to be a little bit more open and understanding that we might have to change the way we do things, the way we measure things, the way we conceptualize health and healing. And I just wanted to put a plug in there for qualitative approaches, because sometimes that lends to the most respectful approaches in kind of starting to learn and understand about these ways of healing and being. So I'll offer that much, but I'm really grateful to have been a part of this discussion, and just look forward to ways that we can make some progress in making these changes so that we can really reach the people and the communities and address the suffering that we are all experiencing. Thank you.
Oh, thank you. Victoria?
Sure.
Right, Dr. O'Keefe.
Thank you. I think a few things stand out. One of the quotes that stands out to me from the first session was from Dr. Warren, when he said, suicide prevention is wellness promotion. And I think Dr. Khan-John was just talking about this in terms of, our tribal knowledges, our tribal cultural strengths. They're really important. And then in the second session, when Dr. Gonzalez talked about funding language immersion programs, or we talked about land-based programs, putting funds into those programs and allowing communities to lead how those programs are implemented and rolled out, I think is really, that's suicide prevention, that's wellness promotion. And I hope to see that shift in ways that people are thinking about suicide prevention and wellness promotion within communities as well. So those are sort of the themes that are coming to mind. Thank you.
Thank you. Justin, you turned green.
Yeah, I wondered if it might be okay to offer a bit of an historical perspective on zero suicides, which is work that I know something about from being involved in it very intimately at Emory Fort Health System. And just because a number of the comments here have made me think about the early days of zero suicide. So this is now an international movement, and it didn't at all start with that aim in mind. It was a traditional grant application process as part of a program designed by the Institute for Healthcare Improvement and Robert Wood Johnson Foundation. And the work at Emory Fort Health System that led to something that we now call zero suicides was a finalist for that 2-year grant program, but did not receive an award. we did not get any new extra additional funding to do the work. But by the time we got that bad news, we were well on our way to what was a social transformation. Now, this was within a healthcare system, but the general idea was to set an audacious goal of eliminating suicide in some defined population, and then figuring out through a process of rapid cycle learning and improvement, whatever it would take to achieve that goal. This was well before the publication of many of what we now call evidence-based practices for suicide prevention. We knew about means restriction at that time, but we didn't know a whole lot about safety planning and other forms of clinical intervention. And so, part of the power of that program was the fact that it was time limited. RWJ and IHI said you have to do all this in 2 years or less. And so the traditional approach of nibbling around the edges was a non-starter. And so I know funding is a major issue, and it's something that I, based on my heritage and my social status, cannot fully appreciate. And I wonder if there's some opportunity for us to learn from some part of the Zero Suicide story to get some work started. I think the conceptual framework of the program is consistent with what I hear from experts on this panel here, that the knowledge is local, and that if we can figure out a way to empower those folks in the clinical system at the front line or in the community, at the point of the interaction with folks who may be suffering, maybe there's some opportunity there. Just food for thought. And thank you, Lisa, for giving me a few minutes there.
So I think we're going to end with a prayer. Sade, on to you. Thank you.
Yes, thank you. I just want to say to Dr. Coffey, we have already done that. And at the next webinar, I'm going to be talking about the implementation of zero suicide in Indian country. And so I didn't know if you were one of those Coffeys. So it's an honor to meet you, because we often talk in our academies about perfect depression care and the Henry Ford story. So very nice to meet you.